So we are going live on YouTube now.
Okay, it is 4:57. About to be fine.
Yeah. Yes, we are actually live on YouTube. So we'll wait people to join because there's one more reminder email is also going.
Okay.
So we'll start in around 3-4 minutes. People have started joining on YouTube. So I think we can start. Let me just then introduce. Welcome everyone to our live webinar on postpartum hemorrhage management and its case study. I'm your host. I'm Arun Agarwal, founder of Janitri Innovation. We are based in Bangalore. And Janitri is a company working on innovations for maternal and child healthcare and committed to innovation on mother and child healthcare to reduce maternal mortality and infant mortality. Postpartum hemorrhage is one of the leading cause of maternal mortality in developing countries like India, Africa, and other South American countries. And early management, early prediction is very important to make sure that we take the right measures at the right time and we'll be able to save lives in those countries or in those settings. So that's what I would love to thank you, Dr. Anju, to accept this particular invitation for providing a very focused session on postpartum hemorrhage management and different case studies. And I hope you all staff nurses, doctors, midwives can enjoy this session and can learn and will be able to implement those learnings in a real-time scenario and literally save lives. We're very grateful to receive 500 plus registration from around 20 plus countries, and I would definitely like to take name. We actually got, let me take, because these are the countries where the PPH is really high and the mortality is really high because of the PPH. So we got a lot of registration like from India, Brazil, Zambia, Ghana, Peru, Ethiopia, Pakistan, Nepal, Japan, Yemen, Sierra Leone, Nigeria, Maldives, Indonesia, Saudi Arabia, Canada, Maldives, Egypt, Argentina, Bangladesh, Uganda, Nigeria, Ghana, Tanzania, Cameroon. And I would really love to, I welcome all the participants, all my dear friends. And it's just a very dedicated half an hour session. So Dr. Anju is one of the leading OBGYN, very expert OBGYN, and having a lot of experience into the real practice, into the obstetrician and managing PPH as well. And working as a professor OBGYN at KGMU, Lucknow, one of the prominent institute of India. So I welcome Dr. Anju. Thanks for accepting the invitation. And I hand over to you. And you can share your presentation and take it through it.
Thank you, Arun. And I congratulate you and Janitri for taking this initiative, which is very important. And so good evening to all friends who have joined us. Today we will be discussing PPH management. I hope the slides are visible. So why do we need to worry about PPH? Why are we discussing this? Why is everyone joining in? That is because hemorrhage is one of the major contributors to maternal mortality. And it is accounting for almost 27% of maternal deaths, which is more than 1/4. And the other important thing, out of hemorrhage, postpartum hemorrhage is a very big chunk which contributes to this mortality. And the other important thing is that it can lead to death only within 2 hours. So it is the fastest killer. All other things like obstructed labor, sepsis, they take 12 hours, few days, but hemorrhage kills within 2 hours. And we need to remember that it is largely preventable and we can manage it successfully to save our patients and reduce the maternal mortality. So most important, we should be able to prevent hemorrhage. We should take all steps we can that we can prevent the PPH. What are the steps which can help us in preventing PPH? First and foremost, because all our countries, we are getting a lot of women with severe anemia, hemoglobin 5 grams, 6 grams, even we are getting women with hemoglobin 2 grams%. So such a woman, even a small amount of blood loss, she will collapse and she will die. So we have to be very vigilant during pregnancy. We need to do the hemoglobin at least once in each of the trimesters. Ensure that it is maintained above 11 grams% so that in case they have a hemorrhage, they are able to withstand it. The other important measure which we must institute is to ensure that they have a skilled birth attendant at the time of their delivery, who is able to use the partogram, who is able to avoid the woman going into prolonged and obstructed labor, who avoids unnecessary induction and augmentation of labor, because any unnecessary intervention during the normal process of labor increases the chances of complications. The birth attendant must ensure asepsis because infection is a big contributor to the occurrence of hemorrhage. And during the second stage, when the baby is delivering, fundal pressure should not be given and the head delivery must be controlled, avoiding episiotomy unless it is really required. So a routine episiotomy is not to be given, and we must control the head delivery to prevent perineal tears. And another major action which we can take to prevent PPH is the AMTSL, or the active management of the third stage of labor. So why do we need to practice AMTSL and how do we do it? Let us look at the why first. AMTSL is important to reduce the amount of blood loss in the normal third stage. It also helps to shorten the duration of third stage, which otherwise is about half an hour. With AMTSL, it is hardly 5 minutes. And you can see if it is shortened to this extent, then amount of blood loss will automatically reduce. And it helps to reduce the occurrence of PPH. So how do we do the AMTSL? That again is very important. There are basically 3 components of AMTSL. First is the administration of the uterotonic, which as per WHO, oxytocin is the drug of choice, which is given 10 international units intramuscularly immediately after delivery of the fetus, after ruling out a twin pregnancy. So as soon as the baby is delivered, and this change has been made previously, long back we were giving methergin with the birth of anterior shoulder, which used to create a lot of confusion. Now, as soon as the baby is delivered, give 10 units oxytocin intramuscularly. The second step is the controlled contraction or the CCT. Now, it is very important that we do not apply traction on the cord till the uterus is contracted. And we expect the uterus to be contracted rapidly because we have already given oxytocin. So traction on the cord is to be applied only once the uterus is contracted. Otherwise, we'll end up causing inversion of uterus. Once the placenta is delivered, we need to examine the placenta and we need to do uterine massage. Uterine massage as a step by WHO has been recommended that we may or may not do, but it definitely reduces the blood loss, ensures that the uterus is contracted and we are feeling for the uterus. So I feel doing uterine massage does not harm the patient in any way. So it is better that we do it. Particularly in our countries where the occurrence of PPH is high, where our women are often anemic and small amounts of blood loss make a big difference to their lives. So when we have taken measures of preventing PPH, but still PPH may occur in some cases. So how do we diagnose it? PPH is diagnosed when blood loss more than 500 ml occurs following delivery. There may be 2 types, primary PPH within 24 hours and secondary PPH beyond 24 hours up to 12 weeks after delivery. So today I will be confining myself to the primary PPH. Now the important thing is that how do we know that she has bled 500 ml? Quantification of blood loss is very difficult, but there are some things such as a brass V drape which is available, which can help you in identifying the amount of blood loss. Here you can see the yellow line is the warning line when the woman has lost 350 ml of blood, and the red line is the action line when the woman has lost 500 ml of blood. But in all cases, we may not like to wait up till the action line. And even if we don't have this brass V drape, any bleeding which is a continuous trickling or which leads to tachycardia or hypotension is significant. So only the absolute amount of blood loss is not important, but the effect of that blood loss on the woman is equally important, because our anemic women who have no reserves are pre-eclamptic women. Preeclampsia is another very important complication which we see very frequently. And in preeclampsia, you know that the expansion of plasma volume is much less as compared to the normal pregnancy. And when there's no expansion of the plasma volume, so the small amount of blood loss will also cause the patient to collapse rapidly. So these are women who are able to withstand even small amounts of blood loss poorly. and they may show changes of tachycardia and hypotension much earlier than the normal pregnant women. So absolute amounts of blood loss are important, but not as important as the clinical picture of the woman. So we need to take action whenever we feel that the woman is bleeding more than she can withstand. And we must look for the causes. The causes, I think you all know, the 4 T's of PPH: tone, trauma, tissue, and thrombin. Out of which, again, atonic and traumatic PPH are the major contributors. Tissue, small bits of placenta inside, or bleeding disorders, they are less commonly seen. So we must know how to differentiate the atonic PPH and the traumatic PPH. As soon as we place a hand on the woman's abdomen, in the case of atonic PPH, we will find that the uterus is soft and flabby. While in a traumatic PPH, uterus is usually well contracted. Also in the atonic PPH, we find that the bleeding is coming in gushes of dark colored blood. While in traumatic PPH, it is a continuous bleeding, usually bright red in color. So traumatic PPH may be due to different tears like the perineal tear, cervical tear, or even once in a while due to rupture uterus, which has occurred in the second stage of labor while the baby was delivering. And we need to repair whatever the tear is there. So today I will be confining myself to the management of atonic PPH, which is more commonly seen and which requires very vigilant monitoring. So how do we manage PPH? We can remember the steps by the acronym hemostasis. H is for help. As soon as you identify that the woman is bleeding more than she should, you must call for whatever help is available. Don't think that I will manage so much and if then the bleeding is not controlled, then I'll call for help. Time is limited. We have seen that PPH women can die within 2 hours. So call for help immediately. Assess the ABC and resuscitate. ABC are the airway, breathing, and circulation. Look for the etiology. The easiest way of looking for the etiology is feel for the uterus perabdominally. And as I said, if it is soft and flabby, it is probably a atonic PPH. If it is well contracted, it is probably a traumatic PPH. Also ensure whether the placenta has been delivered or not. And while feeling for the uterus, massage the uterus. Give oxytocic. If the patient is not responding to this treatment, shift her to OT, rule out any retained tissue, any trauma, and if these are not there, then go in for uterine tamponade. We'll be discussing all this further on in more detail. If still not responding, you have to resort to surgical measures, apply compression sutures. You may do a systematic devascularization, interventional radiology with uterine artery embolization, and the last resort of all, subtotal or total hysterectomy. So after calling for help, we have to look for the ABC. We ensure that the airway is patent, for which we make the patient lie on a hard flat bed with the neck slightly extended, ensure she is breathing and the SpO2 is more than 94%, and we give her oxygen, either by a non-breathing face mask or by a nasal cannula, whatever is available. And we look at the circulation, for which we need to put in 2 wide bore IV cannula immediately. By wide bore, I mean 16 or 18 gauge. not narrower than that. And when we are putting in the wide bore cannula, we must draw the blood sample at the same time for blood cross matching and for other investigations. And by the 2 wide bore cannula, by one we give oxytocin, by the other one we give fast fluids at the rate of, and fluid of choice is always crystalloids, that is normal saline or ringalactate. 5% dextrose or dextrose saline is not to be given in this condition, as that increases the chances of acidosis. Give 1 liter within 15 to 20 minutes. Keep the patient warm, elevate her legs to improve the venous return. Later on, she may require vasopresses, but at that time, you need to give her fluid to maintain the circulation. And important thing is give the fluids above the level of the diaphragm, which means put in the IV cannula in the arms. And we need to put in a Foley's catheter to empty the bladder, because full bladder relaxes the uterus and increases the PPH. Also, we need to monitor the amount of urine output, which will help us in identifying the mean arterial pressure of the patient, because at all places we may not be having internal monitoring available. And always remember, early recognition is the key to survival of the woman. So what oxytocic should we give in cases of PPH? WHO recommends oxytocin is the drug of first choice, and it should be preferred over ergometrin alone, fixed dose combination of ergometrin and oxytocin, carbetocin, and prostaglandins. So oxytocin is always the first choice. Only if oxytocin is not available or the bleeding does not respond to oxytocin, then drug of second choice is ergometrin or oxytocin ergometrin fixed dose combinations. And if the second line treatments are not available or the bleeding is not responding to them also, then only the third choice is a prostaglandin. For prostaglandin also, they recommend PGF2 alpha, but they say misoprostol may be considered as a third line of treatment for the management of PPH, because it is easy to administer. We give it either sublingually, buccally, perrectally. We don't need to give it by injection. And the second advantage of misoprostol is it's low cost compared to injectable prostaglandins. So this is a drug which can be used even in the periphery where we do not have specialized services available. And that is the reason that misoprostol has been included. But otherwise, it has not been found to have any benefit over oxytocin in cases where oxytocin has been given for AMT-SL. So even in the large WHO Gynety trial, they evaluated 3 parameters: additional blood loss more than 500 ml, additional blood loss more than 1000 ml, and blood transfusion. And they did not find any advantage of using misoprostol. So this is just a chart which shows you the different oxytocin drugs. Oxytocin, which is a drug of choice, is given, as I told you initially we discussed, we'll be putting in 2 wide bore IV cannulae. Through one of the cannula, we'll be infusing oxytocin, which is given 20 units in 1 liter. Again, it is given in normal saline or ringalactate, not in 5% dextrose or dextrose saline. So we must remember that. And if you do not have the 1 liter bottles, give 10 units in 500 ml at 60 drops per minute. The maintenance doses, again, 10 units in 500 ml or 20 units in 1 liter at 40 drops per minute. And the maximum dose is not more than 3 liters of IV fluids containing oxytocin. Now, this is important because that means the maximum dose which we can give is 60 units of oxytocin. And remember, do not give it as a IV bolus. Then the drug of second choice, as I said, is ergometrin, which can be given either intramuscular or intravenous. But we need to remember that it is contraindicated in women with preeclampsia, hypertension, heart disease. So a large chunk of our cases of postpartum hemorrhage are already excluded for ergometrin. So that is why ergometrin is being used less and less nowadays. Then 15-methyl PGF2 alpha is a drug of third choice, which is given 250 micrograms intramuscularly, and it may be repeated every 15 minutes up to a maximum of 8 doses. It is contraindicated in cases with asthma. If we are giving misoprostol, it may be given 800 micrograms per rectally or buccally. That is, we ask her to keep it inside her cheek. If drugs are not able to control, and simultaneously also we proceed to bimanual compression of the uterus, where we place our fist into the anterior fornix and apply pressure against the anterior wall of the uterus. With our other hand, we go behind the fundus of the uterus and we press the uterus between our 2 hands, which helps to expel any blood clots and helps the uterus in contracting. Other measures which help us to reduce the bleeding and maintain the blood pressure are: one is aortic compression. For aortic compression, we press just above the umbilicus, slightly to the left where we have the aorta. We press with a fist, and with the other hand, we palpate for the femoral artery on the same side. If our compression is adequate, the femoral pulsations should not be felt. So once we are pressing the aorta, the blood supply to the uterus is reducing, and so the bleeding is reducing. Another very useful measure which we have found is the non-pneumatic anti-shock garment, or the NASG. We are using it quite frequently in our institute, and we have found it to be very effective in reducing the bleeding. Another very important aspect of this is, if you need to transfer the patient, it helps in maintaining the blood pressure of the patient by increasing the venous return. So it really helps if you are not able to treat the patient at your place, or if you need to transfer the patient. Or even if you have done all measures, you are not able to maintain the mean arterial pressure. Many times you will find that if you tie the NASG, you are able to buy time. By the time you can give some IV fluids and blood, because many times blood transfusion is not available immediately. So this garment helps you to buy time for that. Then another very important measure which we have found to be very useful is the intrauterine balloon tamponade, which in the series of events I told you at T of hemostasis acronym. So this again is very useful, and it helps to avoid many a hysterectomy. Different types of balloon catheters are available, like your Bakri balloon, the Sangstake and Blackmore tube. But what we have found to be the simplest and cheapest is to tie a condom over a Foley's catheter. So this is a Foley's catheter, and you can see we have tied a condom over it, and we insert it inside the uterus, and we fill it with saline or water. If we can get warm saline, it is very good. Otherwise, normal saline as such is good enough. And we infuse till the bleeding is stopped. Usually about 300 to 500 ml of fluid is required to control the bleeding. It can be left in situ for 6 to 12 hours. And if the patient is well, then we can gradually start deflating the balloon. Again, it is important, we should not deflate it completely suddenly. We start deflating by 20 ml and at short intervals, we go on deflating. If at any time we feel that the bleeding is again increasing, we can just increase the amount of fluid in the balloon. If all these conservative measures fail, we need to resort to surgery. There are different uterine compression sutures which are available. The B-Lynch suture is good if you are doing a cesarean section and PPH is occurring at that time. Heyman suture is required if the woman has had a vaginal delivery and the cavity is not open. So you just give a through and through suture and tie it over the fundus of the uterus. Another suture which is available is JoJo. The basic principle of all the compression sutures is that you are approximating the anterior and posterior wall. Always use a absorbable suture, never use a non-absorbable suture. So the suture of choice is number 1, chromic catgut. It should have strength also, and it should be absorbable. Previously, there were concerns about pregnancy following compression sutures, but now it has been seen that there's no effect on future fertility. If in spite of this bleeding is not controlled, we may require to do systematic uterine devascularization, where we need to ligate the uterine artery, the uterovarian artery, or if required, the internal iliac artery. And the last resort, of course, is hysterectomy. Now, all of these conditions, they lead to a lot of apprehension and a lot of anger in the attendants, because many times they feel their patient was well and suddenly she has deteriorated. So there are chances of litigation, and we need to do a proper counseling at every stage. And good and complete documentation is also very important. And whenever we are talking to the attendants, we need to be empathetic with them. At every institution, to improve the outcome, we need to have well-defined teams comprising obstetrician, anesthetist, and support staff. As I said initially, you have to call for help right at the first step. It is a teamwork. It cannot be done by one person. And regular drills and regular audits help in reducing the mortality and the morbidity. So every institution needs to do this. So we need to summarize, prevention is always better than cure. PPH leads to rapid deterioration, so time is of essence. You need to be alert, have a high index of suspicion to save your woman, and oxytocin is the drug of choice for prevention and treatment of PPH. So let us all join hands, prevent and treat PPH effectively, because every mother is important to us. So now I will just share a case scenario. Mrs. X, 35 years of age, gravida 6, para 5, all living, has delivered a 4 kg healthy male baby 10-15 minutes back at home. Delivery was conducted by her sister-in-law Now the sister-in-law sees that Mrs. X is gasping. So what may be the cause? We all know one of the major causes is PPH. Other causes may be amniotic fluid embolism, it may be preeclampsia, it may be heart failure, but PPH is a major cause. The risk factors in this case, I don't know, I'm not able to share with you, but the age of the patient, we all know with increasing age, chances of PPH increase. With increasing parity, she is a grand multipara, para 5. The third risk factor, she has delivered a large size baby, 4 kg baby, which leads to over distension of the uterus and increased risk of atonic PPH. Fourth is, she has had a home delivery without a skilled birth attendant. The delivery has been conducted by her sister-in-law. So that again is a risk factor. And with these multiple pregnancies, the chances of her being anemic are very high. So all these are risk factors. How to manage? We have already discussed. Just to revise, call for help. As she is at home, she needs to call the other family members so that one can call the ambulance for rapid transport of Mrs. X. In the meanwhile, if she is able to assess the ABC, feel for the uterus, massage the uterus, at least this much can be done even in a home delivery. And the patient needs to be transferred rapidly to a care center where she can be taken care of. So thank you so much. I hope we will all be better at preventing and treating PPH. And if anyone wants to ask any questions, Mr. Arun will share with me and I'll be happy to answer.
Thank you, Dr. Anju. Thank you for this wonderful session. If you can just stop your presentation, then we can just take few questions.
Okay.
Okay, great. Yes, it was crisp and really informative. And we're getting questions like from Aditi that how to manage a case when a lady arrives at the hospital in active phase, like 5 centimeter dilatation, gravida 3, and hemoglobin 4. How to manage as she is likely to have PPH?
Yes, definitely she's likely to have PPH. So very important, you must counsel the woman that about the risk of PPH. Arrange blood as rapidly as possible. Give her oxygen inhalation because she's already anemic. She may collapse due to anemia during labor. Keep her head end elevated and help her deliver in a left lateral position with the head end elevated so that the stress on the heart is minimum, and make sure that there is no, you do not lead to perineal tears, and definitely do active management of third stage of labor, which is a single most important intervention at this time, and ensure asepsis at all times.
Another question, Ms. Suli is asking that how long should we consider as a crucial period to monitor for PPH?
Following delivery, gradually the concept of labor delivery units is coming in which it is recommended that after delivery, the woman should be kept in the same bed in the same unit and should be monitored. But a minimum of 2 hours, which are considered the 4th stage of labor now, are important for monitoring. And in that period, every 15 minutes, the uterus must be massaged, the pulse and blood pressure of the patient and the bleeding of the patient must be monitored.
Someone, Chaudhary, asking when to give FFP along with the blood transfusion. Any special significance of FFP in preeclampsia cases?
FFP is required whenever you are giving massive blood transfusions. So whenever you require to give more than 2 units of blood transfusion, you need to give FFP, otherwise the blood leads to dilutional coagulopathy. So FFP is required at that time. In cases of preeclampsia, there's no special significance because preeclampsia as per se, unless it is associated with the abruption or something, does not lead to DIC.
Okay.
It causes DIC when there is abruption associated with it. And at that time, you need to manage it as a case of DIC. Otherwise, there's no role of FFP in an uncomplicated preeclampsia.
Enos Abdullah Mehendi is asking, I did not understand, but they're saying that when suture anterior wall of uterus with posterior, no adhesion in future. This is something they have written.
Yeah, this is regarding the uterine compression sutures. And this was a concern, as I said previously, that there may be problems in future pregnancies. But that is why I said we need to use absorbable sutures always. And it has been seen when we are using absorbable sutures, future pregnancies do occur. There's no effect on their fertility.
Okay, okay. Dr. Mukesh Savari is asking that after administering uterotonic at the time of delivery, is there any adverse effect on the maternal health or child development health in future as we are inducing artificial contraction by oxytocin?
A lot of debate is going on because many people are saying we should stop doing AMTSL and we should allow the maternal blood to go to the neonate till the placenta separates. And in fact, that has come as a GOI guideline also. But as of now, because we are facing so many maternal deaths due to PPH and our women are so anemic that we need to persist with doing AMTSL. That is for the better of the woman. So we need to weigh our priorities. Maybe when we are a more developed countries, we don't have anemia in our women, and we are not having so much of PPH, then we can think of stopping this oxytocin. But as of now, we needed to save the lives of our mothers.
Umida Ganevia is asking that regarding hemorrhage after CS, how to manage blood loss of 1.5 liters? Woman received glucose for 24 hours within 3 weeks before delivery.
Received glucose for 24 hours.
Yeah. He's asking that regarding hemorrhage after CS,
yes.
How to manage blood loss of 1.5 liter? That's the question.
So, Beelin's suture can be easily given at the time of cesarean section to control the blood loss. I think that would be and the rest you will give oxytocics, of which oxytocin is the drug of first choice.
Great. So, yeah, no other question. And I think people have enjoyed it, and we will definitely this video will be online all the time, and everybody can go through this video. I thank you, Dr. Anju. But I must also say that PPH is one of the very major problem, and every second is a golden during the PPH. So in our Daksh application, how we have actually built this, we have this referral feature. So when somebody is in the primary or secondary hospital and having the PPH and our Daksh application, and if they refer the patient from our application and the higher health facility, if they also have our Daksh application, so they will be getting all the information in advance, who is coming from where, what is the blood group and all, and they will be prepared in advance.
So we'll be addressing the delays basically.
Yeah, we are actually addressing the delay here using the technology or using a simple application.
Particularly the third delay.
Yeah.
So definitely that is a very useful feature, and it is required because one of the major reasons in maternal mortality are these delays.
And Chaudhary is asking, ma'am, when giving lower uterine compression suture, how do we maintain cervical patency? Shall we insert artery from above?
No, it is not really required because you are not reaching down to the cervix. Even when you are giving the lower uterine sutures, you are giving just below the uterine incision.
Great.
And it is an absorbable suture, so it will open up, dissolve.
Wonderful, wonderful. Now I don't have any other question which is coming up. And thank you, Dr. Anju. Thanks for this wonderful session. And
So thank you, Arun, and thank you all the audience for your interaction. It has really been enjoyable. Thank you.
thank you.